Carmen, do you want to introduce yourself?
I'm Carmen Rexroyd. I'm a family physician at Pendleton Community Care in Franklin, West Virginia.
Perfect, thank you. All right, Jeremy?
I'm Jeremy Hersler. I'm an addiction psychiatrist over at the Lakewood Center in Sheet Lake.
Excellent, thank you. We have a phone number ending in 4179.
Hi, it's Jennifer Boyd, PA from New River Health Center, and I'm driving, but I'm hoping to join on by video here in the next 15 minutes or so too.
Perfect, sounds great. All right, fellas over, oh, and Julianne, fellas and Julianne over at the Pain Management Center.
Julianne Sweeney, exercise physiologist.
Marcosani, chiropractor.
Mark Ruffley, pharmacist.
And Cream, chiropractor.
Perfect, thank you all. And then here, just walking in, you want to start introductions here?
Hi, I'm Laura. I'm a fourth-year pharmacy student. Nicole, fourth-year pharmacy student.
I'm Caitlin Ettinger with Project Echo.
And Charlie Pompey, clinical pharmacist.
Hey, Nisha Motasham, Project Echo coordinator.
Perfect. As I said, a couple people will be jumping on. We don't have the case presenter with us quite yet. So Mark, are you okay if we start with the didactic?
Sure.
Can you guys pull it up on that end?
Hit share.
I don't think do you have it like available for the screen or?
I do, but you won't be able to control it if I pull it up. Is that okay?
That's okay.
Okay, just let me know. We'll get through it.
You'll just have to tell her like next.
You couldn't share it.
I don't think I'll have it. So if I, just a random question, is there something, because I think since you have it up on the screen that I actually could control it, but how do I go about that?
No, you have to share the screen.
Oh, okay.
That's the only way.
I thought the other way. Alrighty. Well, we're going to start out today, instead of start with the case, with some talking about urine. Yeah.
Try it now. It might let you. I tried to give you remote access.
Okay. What?
See if it'll.
Yeah, look at that. All right. I am in charge of the urine. Let's go. So, I mean, as far as learning objectives and whatnot, we're basically going to go over the overall idea of urine drug monitoring, including both screening and testing. Can you guys hear us or me okay? I guess thumbs and whatnot. All right. Couple big picture ideas, but in general, just starting out, trying to click away here. Where does the idea of even doing urine drug monitoring of any form come from? And I always like to use these pictures because they're absolutely impossible to read, yet are where our tax dollars go. So this, of course, is the 2016 CDC guidelines, or at least one version of them. But another way of looking at them is the way that I usually throw it together of really 3 different islands when it comes to an opioid to utilize or not, going over all the other treatments, all that stuff that we talk about in other echo sessions. And then in the middle grouping, or orange, I believe the color is once the choice is made to utilize an opioid medicine, all the specifics for it. You know, how much, the overall dosage, duration, IR, ER, all that stuff. And then the third grouping within those guidelines would be typically referred to as the risk reduction strategies. And with that in mind, yay, it worked. One of those, of course, is urine drug monitoring, or they say specifically testing, and we'll kind of go over today where they're going with that idea. But there's many, if the day ends in Y, there's a pain management guideline that's out there that's probably being created or revised. This being one of the more notorious ones, but they do have it in there. Then back here at home, we have, of course, the West Virginia guidelines, featured all across the, I'm told, globe, but I definitely know country. And there's the website with everything all updated. But even within the 2 main parts of our state, pain management guidelines. The stoplight approach, which you cannot read there, is the algorithm for treatments. But then there's the risk reduction circles that are there. And one of those is, of course, there we go. One of those is, of course, to utilize urine drug monitoring. And big picture too, by the way, when you say risk reduction, it's pretty much inherent that it's for the patient, but it's also for all of us as healthcare professionals as well, for all of our risks along the way. One way of looking at it, I'm a baseball fan. I know of at least one other in the room here with 3-year-olds and T-ball coming up here shortly. Why in the world would I have baseball up here when we're talking about urine to begin with? But it's a trust but verify. The idea within these guidelines of always utilizing urine drug monitoring of some sort at least is just like the Cubs here when they were winning. I don't know if this was the World Series, but when they were winning, check out the umpire. He has to make sure that the person that just hit that home run, his foot touches home plate. If he doesn't, the home run is null and void, and the World Series is over and life ceases to exist. So the umpire is doing the trust but verify when everyone else is celebrating, and that's where we end up going as well too. So urine drug monitoring, again, putting it all together for screening the cup and testing the fancy $30,000 to $50,000 machines, sometimes less. But the goal, typically or stereotypically, a lot of times we end up in that whole trying to get you perception, but really big picture, it's also medication adherence. You could think of, or I can make up cases even on the fly if I'm, gosh forbid, diagnosed with some form of cancer tomorrow and it ends up being painful and I'm a tough guy and I don't want to take my medication for pain and I'm suffering through things and then could be worried about it becoming chronic in the long term. That could be found out via urine drug testing to see if I was actually utilizing the medicine in an appropriate way. So possibly a different way of looking at things than the usual gotcha there as well too. And then everything else we're all familiar with. So starting out with the screening first, the cup. I'm pretty sure everybody's probably up to date with how these things work, but the way that I usually look at it is that it's just like a pregnancy test in the chemistry of how it works. But the thing about a cup is, and here's probably the dumbest thing you're going to hear today, it's not going to tell you, pregnancy test that is, if it's a boy or a girl. Thankfully, people are laughing. I know I'm not losing you here now. Again, dumbest thing you're going to hear today, at least I hope. I mean, hey, who knows what else is out there. But the idea there is that it's not specific. It's very, very subjective along the way, hence being much less costly, of course. But even just in the simple science of it, if you can see, the control line is further away from the urine than the test line for each of these medications or drugs or substances. And the control line has to be there because it's further away to show that the liquid actually went through and whatnot. So that's why there's the whole 2-line idea there, whether we're talking urine drug screening in this case or a pregnancy immunoassay. But it's not at that level of specificity or extreme reliability either. Another way of looking at that is that with the cups, which anytime I say cup, we're just talking screening, of course, there's a lot of false positives, and even more so, as per this article, there's more false negatives. Now, we'll go into a lot more detail on the false positives, but the false negatives part is really a driver for the idea of using urine drug testing as opposed to urine drug screenings. A lot of this comes across in, obviously in clinical scenarios. Something that our school is actually dealing with is also utilizing it for professional students when they're going on their experiential education efforts. I know we have 2 of them here today, actually. The idea of schools across the country, as per the literature that yours truly has looked at, always use screenings, yet if we're teaching in a clinical sense, we usually go towards the testing, usually meaning always. And that's not consistent. It's not doing as we say or do along the way. But big point here is that there's a lot of false negatives in addition to the positives that we'll go into a lot more here as well.
Doctor, can you address why there are so many false positives on the methamphetamine? I mean, I'm interested in the negatives too, but really the false positives.
Absolutely. I'm trying to think, towards the end of this slide deck, there's a couple of cases, and I'm trying to think if I put the ones in there that involve that. So can we? How about we come back to that? Because in case I got
Absolutely.
I have like 24 funky cases, and I know we only did about 5 of them here today because it's supposed to be 15 minutes. So if it's not there, we'll get there anyway. So, okay. Alrighty. And kind of linking to that, perhaps this might actually answer some of it. And again, we're talking urine drug monitoring overall, but here specifically is the screenings, the cups. We don't necessarily run into these issues with urine drug testings because those are the infallible concept. Here are cross-reactants, otherwise known as things that can create false positives on urine drug screenings for 3 hot ones: cannabinoids, opioids, and amphetamines. If a person is utilizing one of the substances in the correlating column here, they can screen positive for the substance in the left-hand column. A lot of these substances, the cross-reactants, are readily available in society. And if we don't incorporate this knowledge into our conversations with patients, if you're going on the negative side, they could dupe us, they could checkmate us like no other. We'll go over, as I mentioned, some cases involving these things, but even, if any of them catch your eye, like even Benadryl can screen positive for an opioid. How does that work? We'll get there. All of these come down to the concept of, if you remember back to that pregnancy test immunoassay slide, it's looking for structures. It's all about just the generalized structure. If there's something similar, the screening might catch it when it didn't mean to. I'll have a better slide to kind of portray that a little bit more intently, but this is not an all-inclusive list because these things can be many slides, but here's some heavy hitters that really can come up along the way. And you guys will get these slides afterwards, of course, but we'll go through some of these case-wise along the way here too. In the big picture though, when we're talking urine drug monitoring, you have your conversation starter, which is the cup. Not really going to do much in a clinical scenario or a legal scenario at all, but the conversation leader, if you could picture, say an ER doc, at least here at Ruby, strolling into the ER room or area with a patient with urine drug testing results, tox screening results in hand, conversation might start different, but definitely will go different than if it was just a screening result in their hand. Because the conversation leaders hold up. That's why they're big, fancy machines that are very costly. That's really big picture along the way, though. So let's go over some patient cases, and hey, why not have a GIF about it as well? So, I guess I should ask, any other, let's go back to home.
We're going to go into GCMS.
Not specifically, but we're going to.
Okay. Interlude then.
Yeah.
So you don't make a clinical judgment on dismissing a patient or for overall compliance based upon these DIP tests, point of care tests. You have to have confirmation with mass spectrometry. So this will tell you that you need further testing if you have concerns.
That's
back to you.
Exceptional point there. The idea, I guess we could even probably go back one. The overall idea here is that that fancy machine there is tagged together with liquid chromatography and, as Dr. Vagliani said, mass spec. It's a combo. It is definitive. There's really no wrongs with that. And those are the things that, yes, would hold up in court and also clinical decisions, whether you're dealing with dismissal or adherence or whatever. This, if you could see the mouse, this wonderful little cup over here is not involved in those high-level decisions. Any other questions before we jump into a couple random case type scenarios? Okay, so here's, we're not going to do the usual like full patient workup and whatnot because I believe we have a echo case for that here. But here's a patient scenario where there was a lower than expected pill count. In this case, we'll say for oxycodone, IRER, whatever, but there was a lower than expected pill count. And this is the results from a urine drug screening panel. It's a 12 panel. There's basically going from 5 all the way up. There's different numbers of them, including more and more substances. But there was a lower than expected pill count, but then their urine drug screening screened positive for oxycodone. So any guesses as to, and there's no completely right answers here, but any guesses as to what could be going on there?
Metabolite.
You're on the hub. I'm yelling at Dr. Bagley
I made a
because
guess. I didn't know that.
turns out even anybody can be really throwing these out here. Because again, it's whatever our outcome is in this case, it might be the polar opposite in real life. It's just what could be going on. So
Too much.
we'll go easy on the, so we have two postulates here from the hub at least. The patient took too much, and then another concern was worried about the metabolites for oxycodone. Any thoughts out there, or anybody encounter anything like this recently or in the past? Or? All right, we'll go with what everybody said then. So as far as the drum roll, so you run a urine drug test, and here what you're seeing is that there's a positive for oxycodone, but Dr. Bagliani is the winner here. There's nothing testing positive for the metabolites, or the relative important ones, for oxycodone. Those metabolites being oxymorphone nor oxycodone. So what could have happened in this scenario was a stroke of intelligence. The person may have had the opportunity to take one of these pills while they're in the waiting room, provide the urine, and the screening and the testing will show oxycodone, but you know that it wasn't in the system longer because the body didn't have a chance to make the metabolites yet. And that's a very, I don't know if anymore it's appropriate to say common, but a very easy way for people to be fooled, one might say, of looking for the rest of them there, where a cup is not going to get you anywhere with that, but then having the test results, if somehow on the same urine even, coming up. So then you run into a lot of other concerns where hopefully you already have a patient and provider agreement or contract in place that stipulates in black and white what will happen once this scenario happens. That way it's low stress relatively, knowing what's going to go on at that point. So any questions or thoughts, Sarah, on this one? Or now, again, I would emphasize, just to be fair here, it doesn't mean that the results here from the urine drug testing are always going to be what would be the scenario here. It's just how we're portraying this one. All right, so I like to keep cases relatively simple. You got a patient and their med list is 3 meds, lisinopril, diphenhydramine, and a multivitamin. They screen positive for opiates. What are you gonna do?
Send for confirmatory testing.
Boom. And what, anybody want to guess? Again, we could have fun with it here. What do you think the results are going to be here?
Non-confirmatory.
Non-confirmatory as in they...
I think it's a false positive, perhaps potentially because of the diphenhydramine.
There we go. And if buttons would work. Cha-ching! So confirmation did say that this patient was actually utilizing diphenhydramine. So thankfully everyone here didn't, it sounded like no one went tachycardic and worrying about their patient here. And hey, what it was only 4 slides ago where we went over this. So, but the idea here, I somehow have managed to in life, haven't quite let my mom know the great news yet, but for some reason I get a lot of, it's not really consults, but questions from people on, hey, my patient's on this, could they screen positive for this? On X, can they screen positive for Y? And really what I wanted to go over here today is just going over how to answer that question, because it's infinitely easy, and I don't like looking smart when it's really not that smart. So how you go about that is, we never want to go to Dr. Google, nor Dr. Wiki. So pick one of them or another one and just look up the structures. And if you notice anything remotely similar, there might be a possibility. So structurally speaking, I did the Google for you. Here's the structure of morphine and here's the structure of diphenhydramine. This is where we make MedChem great again with urine drug screening. Anything looks similar here to anyone?
2 benzenes.
Exactly.
Linked by
I don't know if I pulled it off, but the red if anybody's colorblind, I'm in trouble, but the red is intended to show where there might be a similarity, the two benzenes with the oxygen as well. It doesn't say that they're exactly similar. There's obviously differences in structure, but as far as that little cup that will not tell you boy or girl, that might flag because it's at least semi-similar. And honest to goodness, this is literally what I do anytime I'm asked. I just look at the structures. Is there anything that I would throw my little red on? If it's semi-similar, you can do that. The point of this is that you don't have to memorize that listing earlier, although it might be cool to memorize some of them, but you don't have to. You could always look at the structure. Maybe that's why we all had to take OChem. I don't know. I've yet to find a reason, but does that make sense overall? Okay. All right. So here we have a patient case where the patient is currently not utilizing any medications. Can't make it any simpler. Yet they screen positive for opiates. And on the cup, it is literally opiates, because if you know me, you know I'd usually say opioids, but the cup says opiates, so we'll go with it. What are we doing next?
Confirmatory.
Bingo. Upon that, you got the screening, and right before you run your confirmatory, the patient says, you know what, I drank a few gin and tonics the night before. Does that throw your thinking anywhere else?
Well, unless there's a false positive with quinine.
Good one, Chaz.
Dr. Vaglini says, good one.
Yeah.
Perhaps that quinine had factored in here, because when running the actual confirmatory, there's no worries. So turns out this person randomly mentioning the gin and tonic, it could be a real thing. And then again, this is just from that listing earlier. We're not going to go into searching the structures again. I think doing it that one time with diphenhydramine probably drives the point home. But some of these stories are legit, and others maybe not be, but it always comes down to that. Kind of begs the question, since we've done a couple of these now, of should you do a screening to begin with if in the end you're going to have to do a testing and there's cost concerns and all that, which is why a lot of the best practices, I know what we do here, of course, is going right to the testing to begin with. So that's not always something that's possible for every practice, but just the considerations, and here's some of the reasons why along the way too. So you could even just jump down to there's a patient scenario here, but you could jump right down to the question. Any thoughts on which one of these antibiotics could produce a false positive screening for opiates?
Cipro.
It's not B, because I don't even know what that is.
I don't know if everyone heard that, but
Yeah, I did.
somebody said it's not B as in boy because they don't know what that even is.
I'll say D, Cipro.
Charlie says D. Somebody else said it must be something that treats coronavirus. They're antibiotics, for crying out loud. Anyway.
We probably need another.
All right, so after the drum roll, I believe Dr. Ponte mentioned ciprofloxacin, and yes, the fluoroquinolones have a possibility of producing a false positive screening for opiates. Now, where does that come into play? In a patient scenario, oops, I forgot to tell you that I just got an antibiotic the other day for UTI, and then Dr. Google told me that it might, or Dr. Grofley's slides that are now publicly available told me that this might screen positive, so we just wasted everyone's time along the way. And that's one of the bigger things here is if screening is going to be utilized, you got to have these really concrete discussions of, I need to know everything in your body recently, or else it could be a waste of time. All right, I think this might be one of the last ones here, but so the patient not utilizing any medications, but thankfully, as any and every U.S. Surgeon General has mentioned, the biggest thing we can do as healthcare professionals is discuss and implement smoking cessation. So this person says not currently utilizing any medications as per the EHR, but is undergoing smoking cessation. They screen positive for amphetamines. What do we do?
Probably Wellbutrin. I would say that they're Wellbutrin.
I agree.
I love that you guys and gals are jumping to the answer even before the urine drug testing there. And there are states across our country where a pharmacist can prescribe bupropion or Wellbutrin, as you guys said, for smoking cessation. So it might never even be in the EHR. It's certainly not in the PDMP because it's not a control. So those are things that thinking along those lines. And of course, the confirmatory told us that story. And it helps along the lines with the conversation with the patient too. So this may jump into that whole question from earlier with amphetamines. There's another one that I don't have the case here for, but is everyone familiar with the Vicks, I believe it's called Vapo inhaler, it looks like chapstick?
Yes.
Charlie, you said yes. What's the active ingredient?
Well, if it's Vicks, it's probably camphor, menthol, one of those sorts of. I don't know specifically. I'd have to look, but that's what comes up. No.
You're added into your answer with what Dr. Vagliani said. Everybody's right on that. You got, of course, the way that it smells, so you got your camphor and all those things in there. And once you read the back, it will actually say in a misspelled version, levo methamphetamine.
Really?
So methamphetamine, as I usually harp about, is a legal prescription product for ADHD. It's a C2, but the left-handed version is an over-the-counter product. Now, it is in a dose that should never be an issue in these cases because it would take so much of it, perhaps even on the screening side. But again, you can't really say much with screening cups. But the point being that the abuse deterrent strategy with that was to misspell it so that people don't try and abuse the Vapo inhaler, because if you put on the label that the ingredient's meth, you know what people are going to do. They do the same thing when they were stealing from pharmacies the Oxy products for urinary incontinence because it said Oxy. It's the same concept there. Really funky abuse deterrent thing is just the spelling. But the point is that is actually left-handed, per se, methamphetamine, and it's an over-the-counter product. I know I even utilized as a child, thanks to my mom.
Yeah, so just out of curiosity, you kind of piqued my interest. Why did you put it in there?
I'm sorry, Charlie, I coughed. What was that?
Why was the methamphetamine in the product?
To my knowledge, they don't specify how much is in there.
So it's listed as an active as opposed to an inactive ingredient. You know, I'm just asking. I
wish I could answer that, but I've never.
Any other vasoconstrictor in there like that, perhaps?
That's when you look at the back. That's the only active ingredient listed. They actually don't even list their recipe as the other active ingredients. It's just inherent that it's in there, I guess. And as far as the amount, I mean, I guess it's because it's a recipe, it's OTC, we don't get to know. And I would still second guess even if they said it, just because it's so arbitrary to begin with. So we're kind of left up a creek there on that one of knowing exactly how much. That being said, in the big picture, it's a low amount regardless.
Yeah, so. Right. You'd almost have to have two vapor. You'd have to have two of the nasal products, taped to each nostril, I think, to kind of get off on it, probably, I find that sort of curious. It's a good point.
Yeah. At that point, they look like rockets from Apollo 11, I guess. You got to get enough to go to the moon.
So. Yeah, it would be easy to
So now, because there was the question earlier, there's other things. I have that chart from a couple slides ago, I'll provide for everybody as far as other things for amphetamine, false positives for screenings, but then also just really possibly obvious would be any ADHD meds, your regular amphetamines and whatnot along the way too. So those are some of the bigger hitters or stories as far as those go.
Do you have any information on how many pounds of poppy seed one would have to ingest to have a positive opiate screen?
Yes. I think it's
coming up. Okay. Didn't mean to jump.
No. I don't know if everyone heard the question. So the question was, do you have any information on how many kilos of poppy seeds would it take to get the result that we have on the screen here now, actually for marijuana THC screening positive? So it's actually not that much relatively. The case that I usually have up that I know it's not here is my wife's Aunt Doreen always makes poppy seed bread for Easter. And I'm always wondering, my gosh, am I in trouble on Monday if Rick runs one on me or what? The information that I have most recently seen was that it could possibly only take a teaspoon of poppy seeds to possibly screen positive screen positive for THC. First off, again, it's the screening, not the test. Second off, a teaspoon sounds really small, but if you think about that bagel or that bread or whatever it would be, there's really not that much on there. You know, if you were to like shake it all off, and you probably wouldn't really get a teaspoon. So there's that, on top of it being a screen to begin with. One of the other things is also the breakdown. You can look actually at different metabolites, this and whatnot. The point being that if somebody brings up that case when it's involving a screening, we don't win as clinicians because it could be legit. And that's another reason why you're looking at that mass spec with chromatography testing as infallible. All right, so here, I guess added onto that as a case, patients supposedly not on any medications, yet they screen positive for THC, marijuana. I'll save the question and let's try. Whoa, what's going on here? Good golly. All right, so it turns out that, we already jumped ahead there. What they didn't tell you was that they were down there at the dollar store the other day, because we've got those things everywhere now. And they were gardening and they got sore and they used some of that ibuprofen from the dollar store. Why do I pick on the dollar store? Well, they were recently in the news for having a subpar product compared to other products. So it's not picking on them. There's intent in every part of every case. But anyways, the ibuprofen idea. So did they look up my slides? Did they Google it? Where'd they go and find that out? Or were they legitimately on ibuprofen and screen positive for marijuana? You guys would always answer, of course, run the confirmatory. And when you do, nothing, nada. So it turns out the ibuprofen in this case possibly did cause the false positive screening for marijuana. That's becoming a more commonly known one. Other added on info for this one that at least I find funky, we are not in a cannabinoid talk. That's a much more intense conversation, but many of the synthetic cannabinoids that are out there, your Scooby snacks and whatnot, are actually extremely structurally related to NSAIDs in general. In fact, some of them were created while companies were looking to make new NSAIDs. Perhaps why an ibuprofen or an NSAID, most of the structural classes, might screen positive for marijuana to begin with. So funky info that we all need to know. Again, to have that conversation ahead of time and prevent this scenario and the utilization of one's time.
So Mark, can I ask a
Yes.
question in regards to that? Because it begs the question with respect to NSAIDs. There's 9 distinct chemical classes for NSAIDs. And I don't know if there's frankly any structural similarity. So do you know of any specific classes that are more likely to lead to a false positive cannabinoid? Or is it just, or maybe we're not at that level of sophistication?
I don't, very good question. And I have an answer, I just don't have it for you today. This is the issue with making a 15-minute slide presentation. You don't have your whole kit and caboodle ready. Charlie is absolutely right, and it's a very good point, where there's different structural classes of NSAIDs, just like there's structural classes of opioids. I deleted that slide too. And it all comes down again to the structures for the screening. Now, big picture testing, don't have these worries, so that's an easy way of going around this. Definitely not all structural classes of NSAIDs would screen positive for marijuana or THC. Actually, only a few of them. I cannot remember that info for you right now, but just looking on the surface, it's the like ibuprofen and whatnot. I believe there's one other structural class where they are similar, so those would be the ones to really watch for. That information is not really out there in literature or talked about in webinars, CEs, and whatnot just yet. But if you can tell, I'm kind of on a mission to make that happen, to provide that extra info. So I'll try and remember to include that and send that to Caitlin just to have it for everybody later.
Thank you.
Oh, that's a darn good question. So, all right, apparently I got one more. So here's the patient's medication list as per your EHR. They're on hydrochlorothiazide, lisinopril, and quetiapine. They screen positive for methadone. We're not going to ask the same silly questions. Of course, you're going to confirm. Turns out no methadone in the system. Which one of these meds is the culprit?
Seroquel.
Yep. A very common substance that's abused in our prison systems, actually. One of the reasons I just bring that up. I believe none of us are actually working in a prison. But you never know. Just throwing that extra info out there for a different version of the cases here for false positives. So I believe everybody did very well with that and passed. As the outgoing director of our American Pharmacists Association, I talked to him one time, and he said that all this stuff is great, but what the heck do you do when you catch the car, the dog catching the car? What do you do now? That's what people really need to know, and that's where it gets sometimes dicey, but pretty straightforward too. Once things are confirmed, hopefully, as I alluded to earlier, you're referencing your plan of attack to begin with, where you already went over it in your patient-provider agreement, contract, whatnot, of this is what happens at this point. And it makes it a little bit, hopefully, more easy on everyone. There's always ideas where treatment can continue with non-controls. There's a really big push, hopefully, for the referral to some specialists in this case to help with if there's an SUD in place. If safety arises on whether it's the patient, the care team, the whatever, that's when law enforcement can get involved. And always that, I guess we'll call it the kumbaya quote, but the keeping in mind to respect everybody along the way. People make bad choices every day. We're all there. It's just different levels, of course. So, keeping those things in mind along the way. The patient abandonment is probably the big dicey one, though. Obviously, document everything. Depending on your practice, there's different ways of going about things, but things like having a termination letter come up, proper signing, always having witnesses for that. The duration of Dr. Vagliani is probably definitely better at this one, but the duration of what you would be giving a prescription for might come down to things like half-life of a medicine, so that somebody still has care to go into things. Or, if you have that scenario where, based on the urine drug testing, because that's what you'd be making your decisions on, if you know that it's not in their system to begin with and it hasn't been, then is there really a concern for providing medicine if it wasn't in their system to begin with? Is something that commonly comes up.
That's a common.
He's shaking his head, so we're on the right. I swear we work together.
It used to be fairly common to try to get one more prescription that way, but without chemical in the urine, weaning is complete. And so don't go for that one.
That's a big point, I think, in the overall picture there. So, all right, I promised some others earlier today. So, what's the future got in store? I don't have one of those smart watches yet, but the day might come where, since we have somehow mastered cardiology with these smart watches, perhaps we won't even have to do urine drug testing or screening. Maybe that one of those watches will do it for us and tell you what's in the body right at that moment. That's aiming high. Aiming a little bit lower, I did not mean that pun, are toilets. And it's just, you're talking about urine for a good while. It's going to happen, folks. Caitlin, you put this on YouTube, right? My goodness. That's actually a toilet, very common over in Asia. They're thousands of dollars. Toilets in different continents are amazingly different. That thing will analyze everything. It doesn't do your taxes for you, well, because it's a different country and they don't have the IRS. But it's amazing how these different countries have toilets that will analyze things like no other. Typically, it's fecal matter, not urine. But anyways, just randomly providing that information, obviously, to what the future might hold for all of us. Give your mind a minute there. Keep in mind what's in red. It's not recommended. I used to, in a moment or in days of a lack of intelligence, I remember running pharmacies where you're busy all day, and to have a snack, I was eating cereal, and the easiest thing, the nearest thing to me to hold the cereal was a big old prescription vial. So of course I just put the cereal in the vial and would eat it, until someone slightly more intelligent said, "Do you know what that looks like right now?" And I stopped doing that because that didn't look good. But anyways, this part's just for the laughter part, of course, because there's a lot of technically intense things where we just went over here, or what could become intense conversations and situations with patients. But any other thoughts, questions, or anything? There's a lot more information out there, but perhaps our case person has arrived by this point. But
yes, I have a question if you have a minute. Obviously, I work for a managed care company, and one of the big problems we have is overwhelming amounts of lab testing, particularly for our MAT programs. And I'm wondering if you have an opinion on best practice of when to do the screens versus the confirmatories, and any advice on that. What would be good evidence-based policy on that?
It's a big question, but it's probably an easy one too. As far as best practices and what's recommended, and I think I'm going to have some backup here in a moment, it's urine drug testing. And I love that you introed as a managed care company, because if anyone needs to have those discussions within internal teams, it's the payers. When it comes down to it, testing is the way to go. As per, you could even tell, in case it's not me, I believe the guideline I showed in the beginning it said urine drug testing. And sometimes the devil's in the details, or the really important stuff is in the details. Here at this center, it's testing all the way all the time. These cases here today were just some examples of why people could be wasting time and money doing the screenings. Where on the surface, it's certainly, you run one cup, and depending on the profit of that center, the testing center, it could be anywhere from $10 to $50. So on the surface, it might look like saving money, but then all the time that could be billed, the additional testings along the way, what could happen in the patient's care, ER visits, all that kind of stuff, is predominantly going to be hopefully avoided more so with the testings along the way. So that being said, to be unbiased, our neighbors to the east, Maryland, I believe is where there was some heated headlines when it came to testing companies and screening companies. They're usually one and the same, getting into a little bit of hot water with how their business practices for providing these labs. But that doesn't necessarily mean that it should dictate the standard of care or the best practices. So what do you guys got to add?
If you're making
So when you're talking about, when you're talking about testing, would that encompass like 80307, or are we talking G codes at that point?
Oh, good golly. I remember those numbers because I have charts with them, but I apologize. I can't remember the specific, because it's a dash something is what you're looking for, I believe. It really comes that you can usually tell by what that code is coinciding with the cost. If you're looking at that lower cost, you're going to really rapidly know. I can see about providing some of that info again on the summary afterwards, because I do have some of that. But the cheaper it is up front, the longer it could cost in the long run.
Sure.
You see this question. It's a good one.
Thank you very much.
You're welcome.
Dr. Garofoli, we super appreciate the didactic. That was wonderful.
CBD.
We have. I don't want to jump over here, but there was a question in the chat, and the question, I think it's an important one. It's, does CBD oil turn urine drug screenings positive? All right. So any of you that are going to look this information up, if you just don't go by what I say, I guess, if you're looking it up, you're going to see a lot of information out there that says that it will not. And there's a lot of conundrums with that. First off, we are not in the point in this country, or this globe for that matter, where we can 100% trust what is in the CBD oil from the gas station or from the wherever. And sometimes it's even pharmacies. We're just not at that point yet. It is not regulated in that manner, and I'm not being a proponent for regulation, because we know where things like that end us up with. But at the same time, right now, we can't trust what's in the things 100% of the time, especially as clinicians. On top of that, there's a lot of guidance out there that says, oh, it would be fine because it's not THC. Well, the slide that we had up there comparing diphenhydramine to morphine, if you put CBD next to THC, structurally speaking, I will never be comfortable, regardless of what entity tells me, in saying that there cannot ever be a false screening. Keyword screening again. Again, another reason for the testing. But when you put the structures next to each other, there is such a small difference that it's just amazing. So it really concerns me when a lot of experts, quite frankly, across the country are saying, oh, it will not. My concern is the word will not, or the phrase will not. It may, based on the structure. Observatory wise, it seems like it's not, but it might based on the structure. Full sentence, don't media with cutting out phrases.
CBD is supposed to contain less than 0.04% THC, but nobody tests that in general. And so we've had patients be positive for THC who, when stopped their CBD product for 2 weeks, became negative for THC. Now, they could have been smoking marijuana one time over the weekend, and 2 weeks is enough to get it out of your system. It didn't matter. They complied with the request, and that's what matters. So if the patient follows your direction, you have more evidence that you are on solid ground than if you make a wild guess.
Perfect. Thank you, guys. I'm going to cut us off there. Everybody, I understand if you have more questions, just email them and we'll make sure they get addressed. We do have our case presenter, and I want to make sure we get to her. So, and then I'm going to ask everybody who has recommendations, shout them out quick and simple. So, because I want to make sure we give them to her.
Hi.
Happy to see you.
Thank you. I'm Grace Falbo. I work at Cabin Creek in Charleston, and I'm actually on bed rest. I recently had pelvic surgery, so bear with me, please. I've been seeing this gentleman who is 70 years old, and he has just intractable, severe pain. I started seeing him almost 6 months ago, and I do home visits, and so that's how this started out. He really is barely ambulatory at all. He's in kind of obvious pain when you see him, and he describes his pain as lower legs mainly, also in the knees, but it sounds more like muscular pain. He describes it as really sharp, but he has several occurrences daily where he feels like his whole body just kind of like cramps and spasms. And so prior to me seeing him, he had been seen in the hospital and was found to have an L1 compression fracture. But at the time, there were also some lytic lesions noted on there, and so they weren't really sure the etiology of that. So anyway, I started seeing him. He was already on Neurontin and Cymbalta and an NSAID. And then we were trying to get him in for a bone scan, but like I said, he's barely ambulatory at all. But even just seeing him, you can see that he visibly is having like muscle spasms and cramping. So he has a history of alcohol abuse. He's no longer drinking alcohol. He's got high blood pressure, and he's got diabetes that's well controlled without medication. So we tried again to get him in for the bone scan, and finally we did. And all his labs up to this point have been normal. He was in the past, he had rheumatoid arthritis, but his labs don't support that. He was never on any medications for that specifically. So I guess my question now is where to go from here, because I've done the bone scan and it shows really that there's just some degenerative lesions, I guess, no malignancies or anything, and his labs have been normal. The first visit I saw him, his magnesium was 1.3, and I did start him on magnesium, and I was hopeful that that was the issue, but it's now back up to normal, and he's still just having these severe spasms and cramps. So my next plan was to do an EMG, and we've had trouble getting that scheduled due to transport issues. And I was going to do like some muscle enzymes and some other blood work, but he's a really hard stick. And so my nurse wasn't able to get him at the last home visit we did. I'm not sure if I've given enough information. I have him at this point on, I started him on low-dose Norco along with what he was already taking, and I've kind of gradually increased that a little bit. He does admit to smoking marijuana in the evenings because his pain is so severe he can't sleep. But otherwise, I don't really know if I should, kind of be more aggressive with this pain control. Like I said, he's visibly in pain, but I don't really know where to go from here, or even to figure out kind of what is causing this. I will say one last thing. He did have a CT of the lumbar spine back when he had the compression fracture, and it also showed that he had some pretty significant, an MRI, which was almost a year ago. and it showed that he had multi-level lumbar spine degenerative changes with severe spinal canal narrowing and moderate bilateral neural foraminal narrowing. But neurosurgery has seen him, and they've only recommended physical therapy. He is going to see an orthopedic doctor because he does say he has knee pain as well, but he's kind of a poor historian, so it's hard to differentiate that. And he describes it more as like a muscular pain.
That was perfect, Grace. Thank you so much.
Thank you.
Yeah, I'm going to ask just everybody to shout out recommendations, thoughts, comments, and questions all together.
So Gracie, this is Charlie Pond. Have you assessed his refill history on his opioids to see what's going on with that?
Yes, he is consistent on his refill history.
Okay, so you don't have any, okay. Has he had a DEXA scan?
He has not.
And again, I'm just wondering, I mean, I have so many questions about him. You know, obviously I'm not a physician, but, you know, things that come to mind, you know, does he have sciatic type pain? Is it diabetic peripheral neuropathic pain? Does he have peripheral vascular disease? Has that been assessed yet with him? You know, as at least a component to it. He has the degenerative disc disease, and he has the compression fracture. I was just, you know, wondering, you know, some of these things that you know, that would be also part of the differential, I think, in terms of his pain, and then I would defer the rest of my physician colleagues and my chiropractic colleagues. But those are just some of the questions that I had, and he's obviously depressed, probably, I would guess, right?
Sure. Yeah, I've thought about sending him for some vascular studies. He does have good pulses in his lower extremities. I just kind of want to do the most efficient testing that I can. He's had so much trouble even getting the EMG that I ordered, and so it's really difficult to decide which testing to pursue that would be the most effective for our purposes. And, you know, with his history of alcohol abuse, I was also worried about, you know, that type of neuropathy.
Yeah.
And like I said, his diabetes has been well controlled, although that is on my differential. His last he was 5.2 without medications.
That's without.
Evaluate for injection therapy.
I'm sorry?
Evaluated for injection therapy.
So he has seen a neurosurgeon, and they did not offer any type of modality aside from physical therapy, and maybe I need to pursue that further and discuss with them.
For the diabetes management, I thought it said something about metformin use. Was that a past med or a current med?
He was on that when I started seeing him, and then I stopped that when his A1C was 5.2, but even prior to that, it had been 5.3, and someone had kept him on it, and that hasn't really made any difference.
Well, darn, because I was going to say that it could affect the absorption of vitamin B12, and then we could go
Right.
the elemental folate route.
Yeah, but it was normal.
Yeah.
Yeah, his B12 was normal too.
Gracie, is renal function okay?
Yes, it is normal.
Could the cramping be a focal dystonia, like a neurologic dystonia?
Yes, I do think that's probably on the differential too. So I don't know if an EMG would be helpful.
It's a little out of my scope, but I know that like a psychiatric patient who gets dystonia from dopaminergic antagonists, we use cogentin or amantadine, or and I know things like baclofen and even benzodiazepines can relieve that kind of pain.
Mm-hmm. Okay.
So Gracie, has the diclofenac been of any benefit to him? He's been on it for a long time.
He does not feel that the diclofenac or the Neurontin have been very helpful.
Has he tried other NSAIDs just from a therapeutic standpoint? There's a lot of inter or intra-patient variability with response, and sometimes you can switch different chemical classes and they get benefit. Just because NSAIDs have at least a I think role in bone pain of sorts, and so if you could consider trying a different one.
Okay, yeah, that's a good question. Prior to me, I don't know if he has taken any others.
So that might be worth addressing.
Okay.
in part.
Has he ever complained about especially that below the knee area feeling hot or cold in addition to this crazy lightning pain?
He does say he sometimes has burning.
So with the intensity of as he's describing, the intensity starts getting the mind to go to like those upper level conditions. I don't think it's necessarily there, but things like complex regional and that's where I was going with that thermodynamic thing, but that's really hard to jump there. So
yeah.
I think, Gracie, you would tolerate increasing the gabapentin because you're about halfway to max with that dose.
Well, I guess that's one of my questions too, is, you know, the medication management as far as gabapentin with the Norco, and, you know, I don't want to be too aggressive.
Yeah, I hear you. It's just that sometimes you got to push the GABA, but just, you know, that's just an issue.
Conversely, you could also consider, because he's already, I believe he said that the Norco wasn't really doing it for him, which for neuropathic pain, which I think was the main concern here, that's not really remarkable. So, you know, laying off on that, or since he's saying it's not working, whether it's even needed or not, or the dose going down or whatever. But anyways, back to the gabapentin thing, based on its, there's still lots of wiggle room there, as Charlie mentioned, but perhaps even psychologically a conversion, if covered, over to pregabalin might be an option.
Okay.
At one, because there's just different better absorption, one might say, but then also even in the patient's mind, if you're trying something different, it's, oh, that one didn't work, but maybe this one will.
Yeah, okay. I think that's a good question, and the depression certainly is a part of this. I don't know that I should switch the Cymbalta or leave that the same.
No, that's your best choice.
Okay.
Yeah, for antidepressant effect of Cymbalta, usually 60 milligrams is kind of your maximal benefit, but there are instances where a higher dose may be effective, and I've gone as high as 120. But for the majority of patients, 60 milligrams is a pretty good maximum.
Okay.
You guys have questions? Okay, just.
There are other things you can do to augment Cymbalta. So depending on what kind of symptoms he has, if he's got hypersomnia or hyperphagia, then you might use Cytomel, a thyroid supplement, to help with his mood, or Wellbutrin. You know, so there's different ways to augment. If he's having trouble sleeping, you might use mirtazapine or Remeron to help him sleep and help with his mood.
Okay. Are there any suggestions as far as the next step in kind of testing or workup for this? Like I said, I kind of want to hit the biggest whammy first, if I can. I mean, does anyone think I should do vascular studies instead of an EMG?
Well, just because of his just because of his current history of having diabetes, and he has neuropathic, what sounds like neuropathic pain, so he has to have a microangiopathy associated with that. So he may have, you know, here's the thing, he may have, you know, his pedal pulses may be felt, but that doesn't necessarily say anything about the microcirculation that he has.
Sure.
So I'm just wondering if that, just another thing to consider would be vascular component. Just because, he's certainly prone to it because he has diabetes. Now he has good control, but, you know, I've seen a lot of patients who have poor control, who have no disease, and, you know, you would expect them to have disease, right? You know, with people that run 200 and 300s all the time, they have no complications that are evident, yet you can have people that are well controlled and they have complications, you know, so it's kind of hard sometimes to sort that. So at least in my way of thinking, it's one thing also to consider in light of the, you know, he's got compression, you wonder if he's osteopenic, osteoporotic, he has nerve compression, does he have microangiopathy? There's so many things that I guess could be going on with him. But you know, that you've, I think, turned over lots of different stones. I just, that was just one thing that on my list to consider. So I'll leave that up to your discretion, you know. But
Thank you.
sure.
Thank you so much again, Grace, for bringing this to us. Fellows and Julianne over at the Pain Clinic, do you guys have any final words of advice for Grace?
Thank you all very much.
You're welcome.
Thank you. All right, guys. Grace, I'll send you some of the recommendations I wrote down. Everybody else, we will meet on the 19th. If you have a case to send in, I recommend you do it, well, anytime before the 19th, of course. But we will be taking a short hiatus from chronic pain sessions. You'll get an email about it. We're going to work on some rebranding and relaunching to kind of get a nice push going for the second half of the year. We'll do a whole, I don't know, curriculum, a whole thing. I'll of course email better when I have better words to use for it. But from July to December, we're going to do a 6-month cohort, basically. So yeah, keep that in mind. We will have Jeremy Hirschler talking to us about lifestyle factors for chronic pain on March 19th. And that is all I've got. Everybody have a wonderful day. Bye.
Thank you.
Bye, guys.